Good morning. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. My title today is Benign Lesions of the Uterus. So what we wanted to discuss today, the anatomy of the uterus and the cervix, cervical ectropion, nabothian follicles, cervical polyps, cervical stenosis, endometrial polyps, Asherman syndrome, adenomyosis. Let us start with the anatomical structure. The uterus is a thick-walled muscular organ capable of expansion to accommodate growing fetus. It is connected distally to the vagina and laterally to the uterine tubes on both sides. The uterus has three parts: fundus, body, and the cervix. The cervix, lower part of the uterus, linking it with the vagina. This part is structurally and functionally different to the rest of the uterus. So, what about the cervix? The cervix is formed of ectocervix and the endocervix. The ectocervix is the portion of the cervix that projects into the vagina. It is lined by stratified squamous epithelium and non-keratinized one. The opening of the external os marks the transition from the ectocervix to endocervix. So this is the external os which open to the endocervix. What about the endocervix? This is the endocervix. The cervical canal is more proximal and the inner part of the cervix. It is lined by mucus secreting simple columnar epithelium. The endocervical canal ends at the uterine cavity, begins at a narrowing called the internal os. There is a clear demarcation of this transformation between the two types of epithelium called squamocolumnar junction. So, look at this picture. This is the columnar epithelium of the endocervical canal, and this is the stratified squamous epithelium of the ectocervix. This junction is called squamocolumnar junction. The position of the uterus in normal adults, it can be described as anteverted with respect to the vagina and anteflexed with respect to the cervix. Other position as retroverted, retroflexed. The uterus normally lies posterior, superior to the bladder and anterior to the rectum. This is the rectum, this is the uterus. The fundus and the body of the uterus are composed of three tissue layers: peritoneum, or called perimetrium. This is the outer covering of the uterus. It is double-layered membrane continuous with the abdominal peritoneum, also known as perimetrium. Myometrium, which is formed of three layers of smooth muscle. This is the myometrium. Endometrium, inner mucous membrane lining of the uterus, can be further divided into two parts: deep stratum bassalis and superficial stratum functionalis. And this functionalis is responsible for the cyclic changes in the endometrium and the respond to the estrogen and the progesterone during the menstrual cycle. This is the endometrium with endometrial glands, and this is the myometrium. The ligaments of the uterus include broad ligament, which is a double layer. This is a broad ligament, double layer of peritoneum attaching the side of the uterus to the pelvis. Round the ligament, which extend from the uterine horn to the labia majora by the inguinal canal. Ovarian ligament, this is ovarian ligament, join the ovaries to the uterus. Cardinal ligament, located at the base of the broad ligament and extend from the cervix to the lateral pelvic wall. It gives a strong support to the uterus. Uterosacral ligament extend from the cervix to the sacrum on both sides here. So, what about the benign lesions of the uterus? Benign lesion in the cervix may be cervical ectropion, Nabothian follicles, cervical polyps, cervical stenosis. Lesions in the endometrium include endometrial polyps and the Asherman syndrome. Lesion in the muscle wall of the uterus is adenomyosis and leiomyoma. And we will cover all lesions during this lecture except leiomyoma, which will be in a separate lecture. Cervical ectropion can be defined as a columnar epithelium which is visible on the ectocervix as a circular red area surrounding the external cervical os in women of reproductive age. In this picture, this is the cervical ectropion, the red circular area around the external os. An ectropion commonly develops under the influence of puberty, oral pills, and the pregnancy due to fluctuation in the hormones. Clinical presentation may be asymptomatic one, or in cases with large cervical ectropion, the patient may present with pain at or after intercourse and intermenstrual and postcoital bleeding. Also, excessive clear and odorless mucus discharge. The treatment of cervical ectropion in symptomatic one and in cases with large ectropion include stop the combined oral pills containing estrogen. And prior to treatment, try to do cervical swab to catch infection like chlamydia and other sexual transmitted disease. Also, cervical smear for cytology to exclude cervical CIN and malignancy. We can do cervical ablation. So the visible glandular producing columnar cells are ablated, usually with cryocuttary or electrocautery, as in this picture. This is the ablation of the cervix, and this is the swab, which should be done before ablation. What about Nabothian follicles? It is a small mucus-filled cyst visible on this ectocervix. In this picture, this is an Nabothian cyst containing mucus which is whitish or yellowish in color. The columnar glands within the transformation zone become sealed over, forming this cyst. No pathological significance, and usually it is asymptomatic. No treatment is usually required for Nabothian follicles, although extremely large ones can be drained using a large bore needle or by using electrocautery ablation. If Nabothian cysts occur with chronic cervicitis, then the underlying cause of the inflammation must be treated. The same also for ectropion. The underlying or associated infection in the cervix, as in chronic cervicitis, should be treated according to the organism. The next title is cervical polyps, which is a benign tumor arising from the endocervical epithelium, and they may be seen as a smooth reddish protrusion, as this picture. This is the cervical polyps, mucus gland polyps. The clinical presentation of the patient may be in the form of vaginal discharge, interministral bleeding, and postcoital bleeding. However, many of the cases are asymptomatic, and this case discovered accidentally during local examination. Treatment are easily removed by avulsion with polyp forceps as an outpatient procedure. So we do polypectomy in outpatient clinic. The next is cervical stenosis, which is defined as pathological narrowing of the endocervical canal, which is caused by congenital causes, which is very rare, or acquired iatrogenic one. A surgical event as comb biopsy or loop discectomy and endometrial ablation affecting the os, causing injury to the os or cervical canal, as in the picture. The clinical presentation is due to trapped blood in the uterus, causing hematometria, which will be associated with cyclic dysmenorrhea, with no associated menstrual bleeding or very mild spotting. So, the treatment as in the picture by dilatation of the cervical canal under ultrasound guidance. Also, insertion of laminaria tent or T-tube as a stent for a few days. Next title is endometrial polyps, which is common and estimated to be present in around 10 to 20% of women with abnormal uterine bleeding and 10% of women with subfertility. The risk factors include late menopause, obesity, hormone replacement therapy, and tamoxifen therapy. As you see in the picture, this is hysteroscopic view. The hysteroscope enters the uterine cavity, and this is the polyp seen inside. Endometrial polyps may be pedunculated, has a pedicle like this one, this one. This is the pedicle, or sessile. Single or multiple. This is multiple one, and this is multiple one. And vary in size between 0.5 to 4 centimeter. They are focal endometrial outgrowths containing a variable amount of glands, stroma, and blood vessels. They are relatively insensitive to cyclic hormonal changes. So, it is not responding to shedding of the endometrium under the effect of hormone of the menstrual cycle, or not responding also to hormonal treatment. The presentation of the patient with endometrial polyp may be asymptomatic or abnormal uterine bleeding in the form of heavy menstrual bleeding, intermenstrual bleeding, or postmenopausal bleeding. Or the patient present with inability to conceive. Diagnosis depends on history of abnormal uterine bleeding and investigation by doing transvaginal ultrasound or saline infusion sonography and outpatient hysteroscopy. This is the saline infusion sonography, and this is the saline injected in the uterine cavity, making contrast, and this is a polyp can be seen very well by transvaginal ultrasound. While in the other picture, this is hysteroscopy, and this is the polyp can be seen easily, single polyp inside the uterine cavity. What is the complication? Endometrial polyps contain hyperplastic foci in 10 to 25% of symptomatic cases, and 1% is frankly malignant. This is very important. The risk of polyps harboring serious endometrial disease is increased after menopause and with the use of tamoxifen. So, should be careful with postmenopausal lady with endometrial polyp and those taking a treatment with tamoxifen. This is the endometrial polyp here in the picture of hysteroscopy. The treatment includes polypectomy in order to alleviate the abnormal uterine bleeding symptoms, optimize fertility, and exclude hyperplasia or cancer. We are using hysteroscopy for polypectomy. It can visualize the polyp very well and remove it by scissor or electrodes under general or local anesthesia, as you see in this picture. This is after removal of the polyp, the uterine cavity becomes free. Next title is Asherman syndrome, which is defined as irreversible damage of the single-layer thick basal endometrium, which doesn't allow normal regeneration of the endometrium. The endometrial cavity undergoes fibrosis and adhesion formation. The result is reduced or absent menstrual shedding and subfertility. This usually occurs after pregnancy, where there have been uterine infection or following overzealous curettage of the uterine cavity during surgical management of miscarriage, or following secondary postpartum hemorrhage. As you see in the picture, this is the intrauterine adhesions, what's called Asherman syndrome. The clinical presentation includes secondary amenorrhea or hypomenorrhea and inability to conceive. Investigation to diagnose as hysterosalpingogram, as in this picture, there is filling defect here due to intrauterine adhesions. Or hysteroscopy, as thick adhesions here can be seen very well inside the uterine cavity. Also another adhesion, more thin adhesion here in the uterine cavity. Treatment by hysteroscopic adhesolysis by cutting these adhesions and inserting intrauterine balloon stent to prevent recurrence of the adhesion, as this one, taking the shape of the uterine cavity, triangular. This balloon tries to prevent the adhesion inside the uterus again. And they give the patient cyclic hormonal treatment, estradiol and progestogen with high dose estradiol to help for regeneration of the epithelium of the endometrium. Next is adenomyosis, which is defined as a disorder in which endometrial gland and stroma are found deep within the myometrium. As here in the picture, this is the endometrial gland and enter the muscle wall of the uterus deeply. Adenomyosis can be definitively diagnosed following histopathological examination of hysterectomy specimen, where it is identified in 40% of uteri from general female population of reproductive age. This ectopic endometrium is responsive to cyclical hormonal changes that result in bleeding within the myometrium, making the muscle wall thick, hyperplastic, and fibrosis, and tiny cyst in cut section can be seen inside the muscle wall of the uterus. And the uterus becomes bulky and enlarged, symmetrically in diffuse adenomyosis and asymmetrically in focal adenomyosis. The risk factors include uterine trauma from childbirth or abortion, chronic endometritis, or hyperestrogenism. The etiology includes a widely accepted theory trying to explain the adenomyosis. Adenomyosis results from invagination of Bezial's endometrium into the myometrium through an altered or interrupted junctional zone. Differential diagnosis of adenomyosis includes other causes of symmetrically or asymmetrically enlarged uterus. Adenomyosis occur in the age of late 30 or early 40. Symptoms include dysmenorrhea and heavy menstrual bleeding. Examination reveal bulky and tender uterus, particularly in the perimenstrual period. Ultrasound examination can diagnose adenomyosis very well. Either focal or diffuse adenomyosis can be identified. Also, we can see different signs by ultrasound like myometrial cyst or asymmetric thickness of the anterior and posterior wall, or heterogeneous echogenicity of the muscle wall of the uterus, as in this picture by ultrasound. MRI is investigation of choice with high accuracy in diagnosis of adenomyosis, but it is expensive. It provides excellent image of the myometrium, endometrium, and the areas of adenomyosis. Different sonographic signs of adenomyosis by transvaginal ultrasound. This is the asymmetric thickness of the anterior wall and the posterior wall. We can see the difference. This is diffuse posterior wall adenomyosis. Also, the heterogeneous echogenicity of the muscle wall of the uterus, myometrial cyst, poor definition of the endometrial myometrial junction, subendometrial echogenic linear striation, regularly enlarged uterus and or asymmetric uterus unrelated to leiomyoma. The treatment of adenomyosis include medical treatment by giving the patient non-steroidal anti-inflammatory drugs and hormonal treatment like progestin medications, norethistron acetate and Dynogest, levonorgestrel intrauterine system, Mirena, as in this picture. It releases hormone progestogen inside the uterine cavity. Depo-provera injection monthly, or GnRH agonist like Zoladex subcutaneous injection 3.6 mg every month for 3 months. As in this picture, this is Zoladex. Treatment by surgical one include either aggressive treatment like hysterectomy in patient above 40 and completed her family with severe symptoms. The definitive treatment would be hysterectomy. As one of my cases of adenomyosis, I did hysterectomy and bilateral salpingo-oophorectomy for this case. The other option is conservative surgical options, including endometrial ablation or hysteroscopic endometrial and adenomyoma resection, or laparoscopic resection of adenomyosis, or high-intensity focused ultrasonography for lysis of adenomyosis, or uterine artery embolization. Thank you. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.